Good afternoon, everyone. My name is Dr. Nitin Chawla, and I am Head of Pediatrics at KIMS Cuddles Gachibowli, the Medical Director of CMS. Today onward, we are going to start our webinar series on pediatric subspecialty, and special focus will be on emergency management in pediatric subspecialty emergencies. To go ahead with this is the first talk on approach to respiratory distress in children. Objectively, this talk is designed to focus and help postgraduate students from pediatric side and adult emergency medicine side. Also, for practicing pediatricians who manage acute care in their nursing home or critical care specialists who wish to train their resident doctors or fellows in handling day-to-day pediatric emergencies in their ICUs. Without further delay, we are going to start our talk. For today, the learning objectives will be how do we define and differentiate respiratory distress versus failure? Were the clinical signs which we are aware of and red flags which we are aware of can be objectively help us to manage such cases? How can we apply various available assessment tools? What are the common causes? And also to identify, manage, and start the emergency treatment for respiratory emergencies. If we have to escalate our care, what are the modalities available? And we are going to briefly understand the basic necessities to start and basic understanding to troubleshoot. By definition, respiratory distress means there is increased work of breathing, but there is adequate oxygenation or ventilation which is happening. Respiratory failure means that whatever work of breathing has been increased under distress, end result is not up to the mark, and oxygenation or ventilation, either one of them, is not adequate even after compensation. Point to remember over here is for children or for anyone, respiratory drive is managed till our brain is able to understand the flow of oxygen in and out of our body. Once the oxygen level decreases, then brain responses also get altered. That is the reason bradypnea, that is lower respiratory rate in comparison to the physiological respiratory rate, is a bigger problem in any age group, specifically in infants. When there is bradypnea, it is first sign of impending respiratory failure. So, whenever you come across any patient and you are able to see them breathing faster, they are in respiratory distress. Once you start talking to the family and you understand that now they are breathing slowly and their sensorium is not up to the mark, then this is impending respiratory failure. If there is apnea, then you have missed the bus. So, before we go and understand further, let us briefly touch upon what is existing global epidemiology of pediatric emergency cases globally. So it is one of the most important cause which brings children to emergencies because of respiratory issues. More more than 30% of these children go to PICU and get admitted for further care. As an emergency physician or as a pediatrician, we have a moral responsibility to early recognize, intervene quickly, and help them from unnecessary mortality and morbidity as well. When we talk about India, the most common cause which brings children to hospital emergency is pneumonia, bronchiolitis, asthma, which is seasonal, foreign body aspiration, and sometimes systemic problem of sepsis affecting lungs. The secondary cause of respiratory distress is also a very common cause of respiratory visit in hospital. Pathophysiology of respiratory distress is delineated into few segments. When we do PALS, which we are going to start the free PALS review after 15 days, we understand that it is not only cardiac arrest which causes problem and ultimate end result is death. Always the end result is the end result, but there is a path to that. So the path is airway, where if there is an obstruction because of foreign body or because of viral croup or because of bacterial tracheitis or because of laryngeal edema or because of dental trauma or because of epiglottitis or because of anaphylaxis, anaphylactic shock, there will be decreased airflow. This will restrict air entry for starting the process called breathing. Oxygenation works at the level of airways. When the airway reaches lung, then the work of oxygenation is actually converted into ventilation by the lungs, where if parenchymal disease is present, such as pneumonia, affection of systemic causes of sepsis leading to ARDS, associated loss of parenchyma because of heparinization of consolidation, associated pressure from pleural effusion, presence of congenital cyst, all these cause of parenchymal diseases will decrease the compliance of lung. Now the compliance is the volume which is changed at a set pressure change. So when we talk about compliance, it actually forms the foundation for respiratory critical care, and understanding the physiological derangement is the first plan which you should activate when you really want to help such children. Third aspect to note is neuromuscular or CNS issue, where the brain and respiratory centers are affected and the drive is not up to the mark. So the pneumotactic center is not giving adequate responses for respiratory muscle to perform in synchrony. Diaphragm and respiratory muscles, if they lose control, shallow breaths will start happening. Bradypnea will start happening. Any of above or all of above will ultimately lead to hypoxia with or without hypercarbia. Hypoxia with or without hypercarbia is ventilatory failure. Hypoxia alone is actually oxygenation related problem. Whenever you come across a child in emergency who is not going as per the recommended physiological breakouts, this child is becoming hypoxic. Is your first, easiest, simplest response to act upon. You start them on oxygen, preferably if distress is apparent, you start with high flow devices. As a rule of thumb, when I teach, I recommend start non-rebreathing mask. Cost difference between a normal face mask and a non-rebreathing mask is hardly 130-40 rupees, but the efficiency of oxygen delivery is very, very, very high in non-rebreathing mask. When we go to the word respiration, there are two type of respiration, and these two type of respiration are ultimately disturbed in all the deranged physiological processes which lead to presence of various metabolite in blood which we start checking. What are those? First of all, two type of respirations are external respiration and internal respiration. External respiration means the respiration which we are talking till now, A, B, and C. The A and B is the external respiration. We breathe in air, we breathe out air. We depend on our alveoli for taking care of O2 and CO2 gas exchange. So the orange orange column says that external respiration occurs between cell and external environment. It involves breathing. Oxygen is attached and offloaded from the heme. There are not any cycle of oxidation. We cannot do external respiration if we remove oxygen from the equation. There is need of oxygen and it has to come to ventilatory structures, that is lungs. Mechanism of how oxygen moves into the body is dependent on the pathway and the drive. If you stop breathing, airflow will decrease. If you have congestion, if you have turbulent airway, resistance of your pathway will increase. Ultimately, gas exchange happens at the level of alveoli, which is part of external respiration. And when you take in oxygen and after gas exchange, the inhaled oxygen is loaded on heme and the process of oxyhemoglobin curve starts. Then internal respiration is the process where this oxygen which has been taken by oxyhemoglobin curve is utilized by the cells. It occurs in all the cells of the body. It is not related with breathing. You do not have to actively breathe for internal respiration to happen. That is the reason when you come across someone who has respiratory distress, is going into respiratory failure, and because of cor pulmonale has gone into cardiac arrest, you see elevating lactate. If you see someone in distress, or in case of circulatory failure, let's say of dengue also, as per WHO, there is only one parameter which defines derangement of physiological homeostasis environment, that is lactate. In your blood gases, focus only on lactate. If you want medico legally right approach of one inflammatory or one parameter in ED to define that there is sepsis, there is circulatory failure, there is respiratory distress leading to cardiac failure, go on lactate. Lactate will tell you the status of internal respiration at the level of cells, because there are three cycles which are involved in oxidation. These are Krebs, oxidative phosphorylation, and glycolysis. At the level of cell, if the process of respiration is deranged, either because of acidic behavior or because of poor oxygen or because of bad hemoglobin, either delivery is not proper, or delivery person is not proper, or recipient is not proper, oxygen will not be taken up by the cellular level, and this will lead to increment in end product, which is lactate, which is a product of anaerobic glycolysis. And here we should remember that there is no need of oxygen to actively happen. There is no ventilatory structure which are doing it. It is at a very cellular level where mitochondria, cellular membrane, your electrolytes, everything will work to provide nascent environment around the cell for the process to happen. Why this slide is important? Because when we deal with acute problem, we focus only on the external respiration. But when we start managing such cases, then comes the role of internal respiration to be understood, so that we can employ our knowledge on starting the process of improving oxyhemoglobin curve related changes at the level of cell. If heart is not functioning with inotrope, you start thinking about escalating your care by ECMO. If respiratory drive is not maintained, you ventilate at low level of GCS. If oxygenation is not happening with normal oxygen, you put pressure to push oxygen. If lung is not functioning because of parenchymal involvement, you start mechanical ventilation. All these things are relevant if you understand why you are doing. This is the why of that question. When you compare ventilation and when you compare oxygenation, these are also two different concepts. Because I have invited all the pediatric and adult emergency medicine resident and fellows for the talk, I would like to spend 2 minutes on this slide. So ventilation refers to the movement of air in and out of lung where it is ensured that the carbon dioxide is removed and oxygen is delivered. Whereas in oxygenation, it has nothing to do with CO2 delivery. It only means oxygen ho jana, oxygen delivery at the level of lung, so that tissue will get oxygen. Primary goal of ventilation is gas exchange with adequate air movement, so that respiratory acidosis is not happening and lung inflation is adequately happening. Whereas in oxygenation, focus area is prevent hypoxia, ensure tissue and oxygen receive oxygen so that they need abundant of oxygen to function properly. Ventilation is very important in critical care areas. Specifically, if we talk about NICU, ventilation is essential to keep the alveoli open, especially in preterm infants where surface tension is too high and surfactant deficiency is present. So there's a lot of need of pressure as compared to adult lung to keep lungs open at the first breath. The cry helps us in giving that opening. Tailored ventilation strategies are used to minimize lung injury. We do not overinflate, we do not underinflate, we do not over and underinflate so that we prevent volutrauma, barotrauma, atelectotrauma. Prevention of respiratory failure is very important, and what it helps in further deteriorating the problems such as acidosis and organ damage. Oxygen per se is important for vital organs, for brain to function, for heart to function. And if we do not pick up the signs of hypoxia, that is clouded mentation, poor sensorium, or tachycardia, then we are missing on the bigger picture. We can avoid the complication or further deterioration by picking up hypoxia. Even hyperoxia should be picked in infant, in newborn, in neonate. If we go and start oxygen on someone and we do not restrict our oxygen to an extent of getting saturation of up to 99%, then again we are causing problem. We are actually affecting the younger vessels and we are affecting angiogenesis. Thus, in such cases, ROP happens. Other associated problem of oxygen happens. So we should avoid complications and oxygenation should be done in a justified manner. We should always remember that oxygen is a medicine. In neonate, if it is used adequately, it will promote good growth and neurological safety and development. If it is not utilized well, it will harm eyes, it will harm brain, it will harm chest, it will have oxidative injuries also. Ventilation is what intensive care helps us do the most in managing respiratory distress, in managing bronchopulmonary dysplasia, in managing PPHN in neonates, in managing collapsed lungs. Oxygen is very important because without oxygen delivery, ventilation will not happen. To do oxygenation, oxygen therapy, and inhaled nitric oxide are two modalities of improving oxygen delivery. To improve ventilation, ventilator adjustments, positioning to avoid unnecessary airflow resistance and changes are very important strategies. When we talk about airway, when we talk about breathing, it is important to understand the child's airway is different from adults' airway. The size of larynx, shape of larynx, position, association with other soft tissue, entirely it is different. In this picture, clear discrimination of cylindrical larynx in adult and funnel-shaped larynx in pediatrics helps us to understand the most important change. Vocal cord in the cylindrical larynx is the narrowest part in adults, but because of funnel shape, it is the cricoid ring which is narrowest part in children. And when we talk about tissue, tongue is larger in child compared to size of the mouth. If we compare the space before behind tongue, it is more in adult, less in children. Epiglottis is floppier. It is technically U-shaped and is shorter in adult as compared to child epiglottis, adult's epiglottis. Number two, vocal cords in children are technically placed at upward slant. As compared to that, in adult, it is raised because larynx position will be more anterior and superior in children. The position of vocal cord is like this. Because of funnel shape, cricoid cartilage area is cricoid ring area, which is the first part of child's airway. In trachea, it is less rigid is narrow as compared to adult in children. These soft tissue and hard landmarks are important for you to decide if you are an adult emergency physician. These are also important for you to decide if you are managing adolescent up to 18 years and child of 18 days as a pediatrician. So factors of emergency act on someone's thought process. Having hands-on knowledge on these processes will keep you ready to face unnecessary troublesome problems. In a quick nutshell, smaller diameter in pediatric airway will lead to rapid obstruction. A drop of secretion is abundant for a child to go into distress. That's why suctioning is important. Obligate nasal breather is the reason children cry. When they cry, they tend to open their mouth and breathe while they are crying. So, if you come across a child who was breathing normally in your emergency as soon as they came into your emergency, but at home parent are saying that kid was crying a lot, that means there is nasal stuffiness. As soon as they change their room, nasal opening has happened, nasal cycle has reversed, and now child is breathing from nose rather than mouth. When you see such things, ensure that you manage secretions of nose. If needed, suck them out or you start medication if necessary. Having a higher larynx in children is making them more prone to obstruction. Having a more compliant chest wall lead to more presence of retractions. Nasal breathing is predominant in infant, and with example of a crying child, I have tried to explain why it is relevant for you. Now, objectively, it is responsibility of us to see the patient and understand whether this child is sick, ill, or not sick. There is a very amazing tool called Pediatric Assessment Triangle, which is one of the many tools in triaging. In upcoming sessions, we are going to talk in detail on triaging also. But for today, I'm going to talk only about PAT, which is Pediatric Assessment Triangle. It has three important components. It has appearance, it has workup breathing, and it has circulation. This one triangle helps you to quickly identify and assess and label the child as sick or not sick. And if they are sick, then you immediately predispose this patient either to ICU, or you decide if you do not have adequate resources to transfer to relevant facility. When we talk about appearance, appearance comprises of these five factors, such as tone, how child is lying on mother's or father's shoulder, whether kid is sitting or standing as age appropriate, moving spontaneously, or is resisting examination by physician or not. Whether child is interactive, that is whether child is alert, engaging with clinician, interacting well with environment and reaching for objects or not. Whether child is getting crying a lot or whether child is stopping cry after holding or comforting by caregiver. Whether there is any eye contact, whether child is able to speak or cry as age appropriate. This TICLS, tickles as a mnemonic, is very useful to pick a sick or about to get sick patient. If in this stage child is listless, limp, crying a lot or not crying at all, no eye contact, no speech, lying listless on the shoulder, means child is drowsy, sick, and also can also be sleeping. So ask the parent whether child is sleeping or is like this for last 4 hours. Workup breathing. When we talk about workup breathing, we are only having three important parameters to look at. First, sound. Second, looking at the chest. Third, looking at the nose. Sound, whether you hear snoring, muffled sound, stridor sound, grunting, or wheezing, all are abnormal. Abnormal positioning means child is sitting as a tripod, holding his neck extended with keeping hands like in front of him. Whether child is preferring sniffing position by keeping tragus and sternal notch in one line, or whether child is sitting in a specific posture. If you see retraction supraclavicular, suprasternal, intercostal, substernal, you are leading yourself into a case which is impending respiratory failure. In infant, you might see head bobbing also. Flaring is something which you should never miss. It is enhance and enlargement of nose nares in every breath. God has changed and transformed humans from apes by decreasing the size of nostril and keeping the size of cartilage as same. So if the nose are increasing in diameter at the offset, it is most important way of trying to increase the airflow, although it doesn't affect much, but it is physiological response of body to capture as much as air with pressure it want to. So it increases its respiratory rate and try to increase the size of nose. By increasing the size of nose is called nasal flaring. When we talk about circulation, pallor, mottling, and cyanosis are three important characteristic features where white and pale skin, patchy skin discoloration, or cyanosis, if present, defines whether the patient is sick or not sick. Let us jump and learn step by step with cases. We have a 4-month-old child with cough, nasal flaring, chest indrawing. As per PAT assessment triangle only, I can see this patient is having abnormal work of breathing. I will not go ahead and think I should manage this patient and at home. Admission, yes. This is what PAT helps you. Sick, not sick. If you are in OPD and you start using PAT, you can pick sick and not sick with ease. As soon as you apply SpO2 probe, it is 88 on room air. With above findings, now your thought process is even more reinforced with poor saturations. Appearance is still preserved in this child, or we have not reported in our history. For a 4-month-old, if child is crying excessively and is shaking his head and is holding his father or mother, this child is having normal sensorium, but child is sick at this moment because there is deranged pulmonary graph. Saturation is adjunct, but it is not part of PAT triangle because PAT is primarily made to help you identify whether your child is sick or not, whether nurse is able to pick or not, whether without lot of tech you can pick or not. Once you add tech, you will make a biased decision without looking at the graph of SpO2. If graph is not correct and you label the child as SpO2 67, panic will create. As soon as consultant walks in, SpO2 probe is attached adequately and the graph is now fine and saturation picks up to 94, then you know that it will be a big round of counseling for the parents and lot of scolding for the practicing junior doctor. Second child is a toddler, 2-year-old, noisy breathing, agitated retractions. Saturation we will discuss later, but here we can see that if we are labeling as per PAT, there is agitation, which is a sign of poor mentation, and there are retraction and noisy breathing. So two limbs are gone. So distress is severe. Applied SpO2 probe 85% despite nasal cannula 10. If after oxygenation also, if child is not improving, we have to go ahead and help this child with further modalities of treatment. For an adolescent of 12-year-old with a history of asthma, wheeze is massive. This is yesterday's case with us. SpO2 of 82%. Child is having tachycardia going up to 160, unable to speak in full sentences. This is the child who need urgent escalation. We tried to manage this kid with inhaled corticosteroid, IV corticosteroid hydrocort. He was in status. Ultimately, because of personal reasons, they wish to leave to a different hospital, and we have started doing a follow up of such patients. Kid is still in hospital, but taking time, and parents need to decide of how to proceed further. Important thing to understand is to identify respiratory distress. You do not have to go ahead with adding SpO2. You can look at the child. Look if you can see someone breathing faster in your emergency. This child is in distress, is the bottom line, which I want all of you to remember. Tachypnea is something which you can see movement of frock, movement of shirt, movement of um, uh, chest. If you can see someone breathing faster, it is sign of distress. If you look at the face and nasal flaring is seen, sign of distress. As soon as you lift up the t-shirt or cloth, retraction, sign of distress. If at all there is some agitation and behavior is not up to the mark as per parents, mild agitation is sign of impending involvement of brain. So all are early signs of distress. If we miss them and we are doing less, then we will see these red flags which we should not miss under any circumstance. That is head bobbing in infants, grunting sound like this, apnea, that is no breathing pattern, or altered mental status. All are signs of red flags. Very late signs in respiratory distress are bradycardia or having cyanosis or unable to breathe properly or apnea, just pre-terminal apnea. There is scoring system called Silverman-Anderson score, which is used in neonates to assess how bad is their situation, and we generally try to keep higher score to give to give information as severe distress, and these scores helps us to decide whether surfactant is needed also, along with need of continuous positive airway pressure. So when we talk about Silverman Anderson score in newborn, if you look at the scoring, there are three grade 0, grade 1, grade 2, and it is only look by the nurse which tells. So upper chest, lower chest, xiphoid, retraction, nasal flaring, and grunting. These are the five parameter where in only one parameter you are using a gadget called stethoscope. Rest everything is looking. If you see that the scoring adding is going up more than 7, this newborn is probably neonate is probably having respiratory failure. From 4 to 7 is distress. There is other score called Wood Downey score. This is utilized for children who are having wheeze, children who are having asthma or bronchiolitis. In all the parameters, if it is wheeze, accessory muscle usage, SpO2, consciousness, these three V's, retractions, respiratory rate, and cyanosis. These are five parameters, six parameters which define whether there is moderate bronchiolitis or severe bronchiolitis. These slides are useful for all of you to check, and these score names are important for you to remember that objectively you can assess patient with bronchiolitis in your emergency. And if you notice that in Wood Downey score is between 1 to 3, this child is mild bronchiolitis, score is 4 to 7, you label them at moderate bronchiolitis. There is another thing called modified respiratory distress assessment. It is tool for bronchiolitis. Score happens from 0 to 17 and is useful to monitor severity and need of pressure in oxygenation. This again is going to utilize what you are able to see mainly and learn mainly from respiratory rate, retractions, and V's. And scoring is utilized to help you decide further also how your interventions are helping the child. One of the best thing which has come out in last 5 years is SF ratio. That is ratio between SpO2 divided by FiO2. This is a very important non-invasive surrogate marker for PaO2 by FiO2 if you do not have resources for ABG. SF ratio up to 235 is considered synonymous with PaO2 by FiO2 ratio of 200. So when ABG is not present, you divide your saturation and divide them with the fraction of oxygen you are giving. For sake of an example, if someone's saturation is let's say 98 and you want to check what is their SF ratio, at room air oxygen saturation is 21% to 0.2. So 2 divide 98 divided by 2 is the SF ratio, which comes out to be around 490. If someone's saturation is 80 at room temperature at the level of room, and the SF ratio comes out to be 400, then that does not mean that patient is absolutely fine. So you decide SF ratio in patient on whom you have started intervention, and you use it in an adjunct in place of ABG. If you do not have ABG, you can start giving SF ratio, not on normal patient, but on those patient where you use oxygen. Okay. Acute lung injury and ARDS criteria as per Berlin classification, PF ratio of 200 to 300 is equivalent to SF ratio of 212 to 253. And if PF ratio is less than 200, SF ratio less than 212 is going into ARDS criteria. If PF ratio is less than 100, it is in severe ARDS. There is no role non-invasive without ABG advantage. You should and take care of the patient with whatever is needed. There are two other parameters such as oxygen index, pressure into FiO2 divided by SpO2, and similarly oxygen saturation index, where it is mean airway pressure into FiO2 divided by SpO2. When you have an intubated patient in your ICU, but your arterial lines are not happening, OSI also gives you a very good guide of understanding how you go ahead and manage such cases. If OSI is between 6.5 to 7.8, things are under mild category. If OSI is above 7.8, then it is severe ARDS, a moderate ARDS as per OSI. When we designate different causes and we try to identify the different causes of respiratory distress, in neonates, it is transient tachypnea of newborn, respiratory distress syndrome, congenital malformations, and sepsis. In infant, bronchiolitis, pneumonia, and pertussis. In toddlers, asthma, foreign body, and croup. School age, asthma, pneumonia, and anaphylaxis. Adolescents, asthma, trauma, and cardiac causes. These are some most important causes as per the age, which you should not forget when you are in emergency. Always remember that initial stabilization in any case with respiratory distress starts with stabilizing the airway. Do not forget something called sniffing position. And if there is a trauma, there is no role of head tilt chin lift, it is only jaw thrust. Jaw thrust is the maneuver to maintain airway. Head tilt chin lift is another maneuver to maintain airway. Suction, the suction of secretion is important to remove obstructions and to decrease the turbulence in the flow. Oropharyngeal and nasopharyngeal airway are airway adjunct to technically help smoothen up the process and help to pass the oxygen directly into larynx without any obstruction from swollen nasal mucosa or tongue getting into the path. If there is decreased sensorium and GCS is going below 8 or there is impending kidney failure, you use mechanical ventilation and you intubate such patients. When you notice breathing and you notice decreased saturation or you notice any evidence of respiratory distress, you start oxygen by nasal prongs, and you can also start by face mask or non-rebreathing mask depending on the severity. And as per your expertise, I usually ask non-rebreathing mask. Target SpO2 never 100%. If distress is too much, target 90 to 92. If distress is mild to moderate, target 95 to 98. If saturations or distress is not improving, add pressure to oxygen and consider starting HFNC. CPAP or HFNC, if persistent hypoxemia is present, need to be started. Prepare to intubate if still there is worsening. Do not wait. Important position to remember is in sniffing position, your target is to have the tragus of ear and sternal notch, that is external auditory meatus and suprasternal notch in one plane. There should be adequate anterior neck space and the glabella and the chin plane should be horizontally aligned. This is difficult but is manageable. In older children, you have to manage it by giving a good head rest, which can be a circular ring or a pillow or even a bed sheet being folded. So the plane between glabella and chin is managed, anterior space is better, and the sternal notch and external auditory meters is in line. If we do not, if we use the same thing in infant who have a bigger head, we have to put a shoulder roll to bring this alignment. If we see external auditory meatus and sternal notch are not at the same level, intubation will be difficult. Even if we get even if we get a good anterior space, but glabella and chin are not horizontal, again, this child will have a lot of trouble. So how do we manage? We do some flexion. We gently roll a shoulder roll to help hyperextension of head and balance the headrest to horizontally align the planes. Once we have aligned the plane with shoulder roll, headrest, and glabella chin are in horizontal, external auditory meatus and sternal notch in one plane, anterior neck space is good. This helps the child to reach up to sniffing position and intubation will be successful. If we do not take similar precaution in neonate, again, the child will go into failure and we will not be able to give adequate amount of airway protection and unnecessary trauma during procedure will be seen. Another important aspect once you have started intervention is circulation. After you have secured the airway or you started oxygenating and breathing is supportive, you look at circulation. For circulation, intravenous or IO access is needed. Fluids for shock. If his child is in shock, 10 to 20 ml per kg cautiously should be given. Fluid overload should be restricted and prevented in pneumonia and bronchiolitis. And always remember to monitor heart rate, BP, and perfusion. There are so many oxygen delivery devices. If we are not aware whether they are low flow or high flow, we may miss the right usage. Nasal prong can only be utilized to give FiO2 up to 40%. Maximum tolerable flow is up to 4 liter per minute. Simple face mask can only give up to 40, maximum up to 60. Flow maximum up to 10 liter. Actually, in PALS, it is only up to 6 liter. Non-rebreathing mask is up to 90% FiO2, maximum flow 10 to 15, minimum 10 should be started. HFNC heated humidified oxygen therapy, maximum tolerable flow is 60 liter per minute. When we think about bronchiolitis, let us do with the case 6-month-old bronchiolitis, saturation 86% despite nasal prong on oxygen. We start the child on HFNC. Initial, we go ahead with 2 liter per kg per minute and we start looking for features of improvement. If they are not, then we go ahead and intervene with intubation to prevent respiratory failure. Few basic slides on how to start HFNC. You follow a normal flow of 1.5 to 2 liter, maximum 60 liter per minute. FiO2 should be titrated to get a saturation of 90 to 95, never 100%. Your idea is to decrease workup breathing and avoid intubation. One of the problem with HFNC is gastric distension and thus even pneumothorax can also happen if high pressure has been given. So in 10 kg child, you don't give 30 ml, 30 liter per minute. You give 15 liter or you give maximum 20 liter per minute flow because this pressure can over distend and can burst the alveoli. If you have been managing a newborn, you know that variable PEEP is not useful. They need to get support, and that is supported with CPAP. Difference between HFNC and CPAP is only and only about variability of PEEP. CPAP is not coming with a variable PEEP. It is you decide how much pressure you want to distend and open the alveoli to get recruited. 5 to 6 centimeter of water is the initial setting for CPAP. Indication are bronchiolitis, respiratory distress syndrome, even pulmonary edema. It helps in improving the functional residual capacity, reduces atelectasis. Contraindication is untreated pneumothorax because this distension will further increase the pneumothorax. When we talk about second case, pneumonia, which is seen with fever, tachypnea, indrawing, we stabilize with oxygen, give heavy antibiotic, give fluid. You monitor and take samples to rule out sepsis because meningitis and sepsis are complications which are very commonly seen with pneumonia in infants. Make sure you escalate as we have learned on identifying distress. And if you see oxygen alone is not working, you add pressure by going non invasive first. If still worsening, secure airway with mechanical ventilation. In croup, which is commonly seen in this season in India, where there is barking cough, character, and presence of stridor, make sure you don't agitate the child. Let the child be comfortably sitting in mother's lap. Manage with nebulized adrenaline, even with steroids. Some people, including me, have used IM steroid as well. Escalate to pediatric intensive care if deterioration in distress is noticed. Do not take risk because in croup there is a sudden deterioration can lead to respiratory failure. Asthma is another very common ailment which affects many children in India. 7-year-old severe wheeze, SpO2 85%. You start with oxygen, prefer Levolin, give ipratropium if age indication is present. These are only bronchodilator. To manage the inflammation, need of steroid is mandatory. We are going to discuss specifically on asthma, GINA guideline, usage of cough nebulizer, MDI in upcoming lectures. If you do not see any improvement, you go ahead to manage with magnesium sulfate, intubate, and use NIV. This is a pressure volume curve where you decide whether the patient is on ventilator is actually doing good. I have kept this curve to help you and understand the very common PV loops which we try to see on our ventilators. So this curve is actually relevant for all practitioners of any specialty. If you see in this is the line which connects the beginning of inspiration and the beginning and end of inspiration. This is the only point when airflow is zero. This is the time which tells you about static lung compliance. The pressure valve, the flow and volume, pressure and volume, these are different aspects which are categorically seen on X and Y axis. When you see this line and you develop a graph, you should understand the relevance of these points, relevance of this area, relevance of this marker. It looks like a fish with a very small tail. The small tail is actually the small amount of effort by the patient to produce a negative pressure to trigger the ventilator. At this point, the rapid inspiratory flow starts happening, and this produces a rapid rise in the pressure, some of which is due to airway resistance and some is due to resistance of collapsed alveoli. At this area, we see that the breath has not transformed into expiration, and here the expiratory valve has opened and the pressure decreases immediately. This pressure decrement is stabilized up to the level of PEEP which we are providing in the ventilator. We commonly come across this graph and discuss on forums. Hysteresis is one thing which we all come across. Hysteresis is the difference and the graphical representation of some properties a, of something. Here it is lung. When the act is in a different direction, when we are giving breath, the act is inspiration, and when we are not inspiring, we are expiring. That is expiration. So different amount of work and different amount of change in the same organ at different times develops a graph called hysteresis. Here we can see the imaginary line which we have drawn, the amount of resistive inspiratory work, amount of resistive expiratory work is the work which lung has to do, air has to do against the lung, and elastic work against all the elastic component which are present for the air to pass generates this type of curves. We will discuss in further presentations on all these aspects. For the purpose of discussion, we come across such graphs, we come across words called compliance, we come across hysteresis, we come across beaking, we come across PV loops, we come across PV loop with beaking. All these things are very important for anyone to understand how we manage respiratory distress. Starting oxygen, starting HFNC, starting CPAP, ultimately starting mechanical ventilation, all is needed to you for you to understand how much you have to give, for how long you have to give, or are you actually adding more problem or you are helping the patient. If in volume you see this type of beaking present, that means you may cause problem to this patient. We will discuss when, well, after in upcoming lectures we will discuss all this. This is a protocolized way of handling status asthmaticus. You try to start oxygen to keep a saturation between 94 to 98. You give systemic steroids. You give nebulization with ipratropium bromide and salbutamol if age is appropriate. Even if it is not being managed, you give magnesium sulfate. If it is not getting better, NIV is still not better, intubate. For bronchiolitis also, for a 6-month-old, chest indrawing is seen, SpO2 going up to 88%. It should be supportive only treatment as per policies. You give oxygen, you hydrate the child. But if there is more distress, supportive treatment do not stop you from starting support with pressure. You start HFNC, involve CPAP. If still severe, you go ahead and even intubate such children to prevent apnea and exhaustion. Always remember unnecessary usage of bronchodilators, steroids, and antibiotic in bronchiolitis is discouraged. You should never go ahead as first line in this. If child is in PICU and you notice any evidence of infection or you have antibiogram showcasing that your ICU is brewing bugs, probability of adding antibiotics is useful. Desperate move of adding inhalational steroid, IV steroid, many doses are not recommended. For now, we are not going to discuss on neonatal RDS. We'll jump to foreign body aspiration. Two things which I want you to remember. This is something which all of you should be prompt Heimlich maneuver to prevent damage to anyone who is nearby. On screws also, you can prevent someone from dying. To completely obstructed airway can be opened by doing Heimlich maneuver. Always avoid finger sweep blindly. If at all there is foreign body and presence of sudden cough with unilateral wheeze, the definitive treatment remains rigid bronchoscopy for foreign body aspiration and nothing else. There are certain investigations which you should not forget to start in respiratory distress. First is SpO2, second is ABG to look for gas exchange, X-ray to help you to understand level of parenchymal involvement, focus to give you B line consolidation and effusion, and septic markers by CBP CRP culture if you're thinking about infection. Always remember and do not forget to document whatever you have seen and dispose them wisely after understanding objectively. If mild distress is there, you can discharge. If moderate is there, you can admit to ward. If severe or unstable patient, if you do not have PICU, then transfer. Document arrival time. Mention objectively under PAT assessment what all interventions you have done, what were the responses, what is the scoring system you have utilized, and communicate well with the parents so that they work as part of your team. With this, I will conclude my presentation. And if at all there are any questions, then we will take the questions now. Do we have any questions?